Wonderful. Thank you so much, Alex, and good afternoon, everybody. I'm Michael Lampierre, Director of the Center for Youth Justice at Georgetown University's McCourt School of Public Policy. And on behalf of CYJ and on behalf of our partners at the Health and Reentry Project, I want to welcome you to today's webinar. We really are so delighted that you're here today for this conversation, which is really focused on a critically important topic, which is how we can best meet the health needs of young people who are involved in the justice system, including those young people who are reentering the community after facility stays and after incarceration. We know from the research and from our experiences that system-involved youth often have a plethora of health needs. This includes physical health needs, mental health needs, behavioral health needs, and these are needs that must be met if we're really interested in positioning them to thrive. Fortunately, at the federal level, both Medicaid and the Children's Health Insurance Program, or CHIP, provide vehicles for helping young people get access to the types of health services that we know can make a difference in their lives. So we're here today to talk about how states can leverage recent federal policy changes in order to use Medicaid and CHIP to connect young people to health services and support the overall continuity of care on their behalf as they re-enter the community. We're joined today really by an all-star panel of speakers, including Vicki Wachino, who's the founder and executive director of HARP, Margot Cronin-Furman, who's the chief of staff of HARP, Lisa Pilnick, director of the Child and Family Policy Associates, and Lisa Belmarsh, who is the Assistant Commissioner for Support Services at the Massachusetts Department of Youth Services. If you want to learn more about these speakers, we are posting their bios in the chat now. They're really amazing partners and leaders in the field, and I wish I could say more about their backgrounds, but we have a limited amount of time. We're also here in many ways to bring to life a wonderful issue brief that was recently released by HARP in partnership with Lisa Pilnick. If you haven't read it, please do so. We highly encourage you to do it. We're sharing the link in the chat as well. It's called Improving Health and Safety as Youth and Young Adults Leave the Justice System. The brief is fantastic. It provides an overview of what we're discussing today. We really encourage you to check it out. And I'd be remiss not to mention that the paper would not have been possible without the generous support of the Robert Wood Johnson Foundation. The way that we're going to move forward with the webinar today is as follows. Lisa Pilnick and Margot will start with a brief overview of why supporting the health needs of young people involved in the justice system is so important, highlighting some of the data points that we know nationally. We'll then delve into the role that Medicaid and CHIP can play in helping connect system-involved young people to vital services and talk about key themes that are emerging from the implementation of new federal policy changes that we'll discuss in 3 states in particular, Massachusetts, North Carolina, and New Mexico. And then Vicki will lead a conversation with Lisa Belmarsh from Massachusetts to talk about how the Commonwealth has been leading its own implementation of the new Medicaid policies and its efforts to meet the health needs of system-involved youth. As Alex mentioned, we do intend to hold a Q&A at the end of the webinar, so please be sure to submit your questions in writing in the Q&A box. We'll do our best to address as many as possible. And then finally, we are recording this webinar. We will share the recording and we'll share today's slides as well. So with that, I'd love to turn the floor over to Lisa to get the conversation started. Thanks again all for being with us.
Thank you so much, Michael, and thank you, Michael and Alex and the team at Georgetown for hosting us, and HARP for letting me be part of this really important project and paper. So excited to speak with you all today. Thank you for joining us again. And I was really excited to see that the number of attendees, or the span of attendees, really includes professionals working across youth justice, health, child welfare, many different fields. And so this is definitely a topic that requires cross-system collaboration. So I'm so excited you're here. And I do want to sort of start with a little bit of quick framing, especially for those of you who don't work in youth justice every day, just so you can get a sense of the population who could potentially be supported through these new policy changes that we're going to talk about. So in terms of the youth in the justice system, as you can see here, 30,000 youth are incarcerated in juvenile facilities, according to a one-day count that's done every year. And there's an estimate. It's very hard to get some of these numbers, but there's an estimate that 166,000 young adults ages 18 to 25 are incarcerated in adult facilities every day. So those are based on single day counts. So obviously in a given year, we're going to be seeing many more young people working with justice systems. Now, in terms of trends, that first number, the 30,000, that was over 100,000 in the one day count in the year 2000. So this is a really significant drop, but we do need to be sort of paying attention to the fact that although we've been dropping for decades in those numbers, there have been some increases in the last few years. And also the disparities in who is incarcerated are deepening. So we now see Black youth are incarcerated almost 6 times as often as white youth. And so we need to be just sort of looking at those numbers when we're offering services and trying to make improvements to how our systems work with young people, really making sure that they can reach all young people. And if you want citations for these statistics, those are available in the paper. If you like to dig into the data and the details, there's a lot more information in there. So on the next slide, this just talks a little bit about the health needs of young people, not just when they come into the system, but really overall over their lifespan. And so we know that young people enter the youth justice system or sometimes the adult justice system as young people with higher rates of physical and behavioral health needs. And then we know that incarceration can compound those needs and add new health needs. And part of that is because anytime you take a young person out of their home, out of their community, you disconnect them from health and well-being supports, from adults who care about them, and you put them in an incarceration setting, which can be traumatic. All of that is not going to help them develop into, healthy adults. And that's part of why justice systems across the country have really worked to get those numbers to decline in the ways that you saw on the previous slide. So young people enter with higher rates of physical and behavioral health conditions such as asthma, hypertension. You'll see some other examples on the slides. But also, we know that young people are likely who've experienced incarceration have worse health outcomes in adulthood than their peers. So things like just being able to climb stairs, they're more likely to have problems if they were incarcerated as young people. We also know that there's a lot of behavioral health conditions and there's substance use disorders, PTSD, depression, and these are really high numbers, both in terms of, again, coming in and when you look at studies that follow young people for long periods of time after, again, I have a lot of really detailed links and studies and stats in the paper, but we just wanted to give you some grounding during this quick webinar. And then I also just want to call attention to the fact that, as it says in this last bullet, young people who enter the justice system with high rates of past trauma, they have adverse childhood experiences, they've often experienced abuse or neglect or homelessness, so they've had a lot of other system involvement before they enter the justice system. Some of the statistics that we've seen are that almost half of youth who enter juvenile justice or juvenile detention have past involvement in the child welfare system, either while they are entering or earlier in their lives. And your community might not use the term child welfare system. They may use child protection or child and family services. Just in case some of the terms I'm using are unfamiliar, I want to use a few different versions of the term so that it may be similar to what you hear in your own state. And then also, I just want to flag, and Margot will talk about this a little bit more, but the Medicaid policies we're discussing They extend even longer, like to a higher age for young adults who've experienced foster care. So when we look at that population of young people who really may have been underserved or have even higher levels of needs, these policies that we're talking about, if we haven't been able to meet their health and well-being needs to the point, during foster care, after foster care, where they end up involved in the justice system, this is another opportunity for us to try to meet some of those needs. And so this is a really good opportunity to really look at that particular population of young people. And again, it's young people who were in foster care. Um, so thank you. The next slide I want to talk about is just this last piece. And basically, one thing to kind of keep in mind is that when you talk about young people in the justice system, actually, the majority are covered by Medicaid or CHIP, or they're eligible for Medicaid and CHIP. Um, Previously and currently, there are some limits on what kind of services you can get covered and coverage, Medicaid coverage during incarceration. And so in the past, when young people would enter incarceration, they would be not that they wouldn't receive health services at all, they'd be completely cut off, but they wouldn't have that continuity of care that is so important. And so these Medicaid provisions really give us an opportunity to make sure that the continuity of care is happening. And again, this is one of those things that feels intuitive because it's true, but basically, when young people have their health and well-being needs met, they are less likely to get involved in justice systems. So we know that, from research that healthcare and health coverage gives not only better health outcomes for young people, but also lower rates of justice involvement, less frequent rearrest rates, reincarceration. So that's a really big contribution to community safety and to the individual safety and health and well-being of the young people who are receiving these services. And then again, I really encourage you to look at the paper. We've got a lot more details if you want to get into the sort of nitty-gritty. But that's just kind of the quick overview we wanted to give you on some of the health aspects. And then Margot's going to talk a little more about the policy, and then I'm happy to answer any questions that anyone has at the end. We're going to have a lot of time for that. So thank you.
Thanks, Lisa. I'm going to spend a couple minutes grounding us in some of those policy specifics. So since January 2025, states are required to use Medicaid and CHIP to cover a limited set of services for incarcerated youth who are soon to be released. This graphic on the slide breaks down the who, what, and when of this policy for us. So when we look at the who, the focused population includes 4 components. The first is somebody has to be eligible for Medicaid or CHIP. And that can vary a lot by state based on income and other factors. The second is that they have to meet the Medicaid definition of youth. And so what that means is somebody who is under age 21 or a former foster care youth under age 26. As Lisa mentioned a few minutes ago, that is a really important target population. So it's exciting that they're included. The third aspect is they have to be incarcerated, and they actually have to be post-adjudication. And they need to be in the 30 days prior to their release from incarceration. The services that are covered under this policy are screening and diagnostic services and a targeted case management. I'm going to get more into the details of what those services mean on the next slide. When it comes to timing, those screening and diagnostic services need to be provided 30 days prior to release or shortly after release, which is defined as within 1 week or soon as practicable. Case management needs to be provided in the 30 days prior to release and at least 30 days following release into the community. This policy applies to all state, local, and tribal facilities where people are incarcerated post-adjudication. So that means juvenile justice facilities, youth corrections, as well as adult prisons and jails. We're not going to talk about it here, but it's worth mentioning that there's also a state option to use Medicaid to provide comprehensive services for youth pending disposition of charges. Essentially, full Medicaid and CHIP services for beneficiaries during their entire stay. So let's get a little bit into these services and how they support youth. Screening and diagnostic services under this policy are designed to identify a youth's physical, dental, and behavioral health needs. The service is designed to connect into the state's early and periodic screening, diagnostic, and treatment program, or EPSDT. And so EPSDT is, as some of you may know, is the comprehensive and preventative care services for all youth who are enrolled in Medicaid. It's worth noting that states have some flexibility when it comes to the screening and assessment tools they're using under this policy, meaning that they have a really exciting opportunity to leverage strong evidence-based screening and assessment tools. You can learn more about some of those tools that have strong evidence bases for justice-involved youth in Appendix A of the paper. Targeted case management services under this policy include a comprehensive assessment and development of a person-centered care plan. This plan leverages the screening and diagnostic information described previously, but it also includes information about educational and other supports that a youth may benefit from. Targeted case managers also make referrals and do warm handoffs to community providers at release. The blue call-out box on the slide lists some of the types of services that youth may be connected to, and they can include healthcare services for chronic or acute conditions, behavioral health services to treat mental health and substance use disorders, specialized services for folks with high mental health or developmental needs, interventions that support families, education and vocational supports and training programs, and advocacy and mentoring programs. Appendix B of the paper goes into these services in more detail. Targeted case management also includes monitoring and follow-up activities to ensure that a youth effectively connects to those necessary community services and has what they need. As Lisa noted earlier, this is a population with pretty significant health and social needs. And so ensuring that a young person leaves incarceration with their needs identified, connections to appropriate community services, and active Medicaid to finance their care has a real opportunity to ensure that at-risk youth actually receive the services they need to stay healthy and safe. We're going to transition now to talking a bit about how states are starting to turn this policy into a reality and some of the lessons that we're getting from states' early implementation. So the paper highlights some insights from interviews with New Mexico, North Carolina, and Massachusetts about this implementation work. You're going to benefit from hearing from Lisa Belmarsh in Massachusetts in just a moment. But first, I want to highlight 3 key strategies that emerged in our conversation with states that are highlighted in the paper. The first is the importance of collaboration across agency and sectors, including community-based providers. Fundamentally, this is a Medicaid policy change, but corrections and community partners are just essential to making it real. In a lot of places, these cross-sector partnerships between Medicaid and corrections just doesn't exist, or it doesn't exist in a way that's really necessary to carry out this kind of complex policy change. States identified several key partners in this work, and they included folks like Medicaid agencies, Health and Human Services, departments of juvenile justice, departments of children and families, departments of correction, as well as non-state agencies, folks like managed care plans, community health care systems, community health providers, reentry organizations, and others. States described to us benefiting from developing cadences of regular cross-agency planning meetings and developing specialized work groups to support alignment on implementation processes and their approach to implementation. New Mexico highlighted how one of these meetings, an in-person meeting of cross-sector partners, helped them create some of this team cohesion around implementation and helped them feel like they had more buy-in to the process. Their collaboration also helped them identify some gaps in their team, leading the Child and Youth Family Department to hire a Medicaid billing specialist to partner with them on the implementation work. The second strategy I want to highlight is promptly enrolling all eligible incarcerated youth in Medicaid. And that's as a means to ensure that all those appropriate services can be covered and paid for by Medicaid. States described setting up processes to make sure that they were screening for eligibility and enrollment upon entry to custody, so they could get that information really early in a person's stay. This allowed them to ensure that eligible youth who are not enrolled in benefits can apply for them. They also describe leveraging technology to facilitate linkages and more efficient communication between corrections and Medicaid on Medicaid eligibility. For example, in North Carolina, the social workers and other providers in both the adult and juvenile systems actually are able to access the state Medicaid information systems to get the real-time enrollment information. We were really excited to hear that, both because information sharing across sectors, especially between corrections and Medicaid, can be really challenging to facilitate. And it's such a tangible example of how the work of creating these cross-sector partnerships can lead to smoother processes for carrying out services. The third strategy that I want to highlight was to start release planning early and to partner with community providers to ensure continuous services at reentry. Again, this policy is designed to create continuity and prevent youth from falling into gaps between the corrections and the community health systems. To avoid that, states described working to ensure that relevant screening and assessments were done at arrival and that information was actually fed into the reentry care plans. They also described the importance of identifying and engaging relevant community partners early in the process to avoid any gaps at release. In particular, they described the importance of connecting with managed care organizations. And MCOs in North Carolina and many other states are actually serving as the targeted case managers that follow youth post-release in that post 30-day period. It's also important to note that not every community has the same resources and services available. This is relevant to decisions about who is providing the screening, diagnostic, and targeted case management services in the facility, who is providing the targeted case management services outside the facility, whether services are done in person or telehealth, and what kinds of other services a youth can be referred to at release. New Mexico described needing to give their facilities a lot of flexibility in response to the diversity of resources available across the urban and rural communities in their state. I'm going to pause there and take the slides down and hand it over to Vicki and Lisa Belmarsh to talk in a bit more depth about some of Massachusetts' early implementation experience. Vicki?
Thanks, Margot. It's so great to be here with everyone today talking about these critical issues. I want to just start with a few notes of gratitude. First, to Lisa Pilnick for lending her expertise, which really powered the paper. To Margot for delving deep into the policy and really seeing and explaining the moment of opportunity here. To Robert Wood Johnson for its support of the work, to Center for Youth Justice for partnering with us, not to mention their longstanding commitment to the well-being of youth. And then finally to the 3 sets of state officials who shared their experiences with HARP that we summarized in the issue brief in Massachusetts, North Carolina, and New Mexico. All of their leadership was inspiring. And we found that as we talked with them about implementation of these provisions, which, as Margot has highlighted, apply not just to youth in the juvenile justice system, but also to young adults in prisons and jails who are up to age 21 or up to age 26 if they were former foster care youth. We found that all of these states were really leaning into implementation in their juvenile justice systems, and that was really where these early implementation lessons of these provisions that are just taking effect this year were really clearest. And we highlight many of those in the paper and are thrilled that Lisa Belmarsh from Massachusetts is here with us to just share a little bit about one state's experience in implementation. As you've already heard, Lisa is the Assistant Commissioner for Support Services in Massachusetts Department of Youth Services. There she oversees a range of services from substance use to education. She's a lawyer by training and in previous roles worked as Director of Policy in DYS, worked in Boston's Law Department and for the Massachusetts Parole Board. So we are just thrilled to have her here today as an example of one of the state leaders who is actually translating these new policies into an on-the-ground reality for youth and young people. So Lisa, I hope I haven't stolen too much of your thunder there, but I thought I might just turn to you to start by just telling us a little bit more about yourself and the role that you play in DYS.
Sure, thank you. And again, thank you for everybody. This is a great opportunity to both highlight what we're doing, but to learn what we could also be doing from other places, including yourselves. So as noted, I'm the Assistant Commissioner for Support Services at the Massachusetts Youth Department of Youth Services. And what that entails is that I oversee the departments of our health services, clinical services, substance use services, education, and our employee support and assistance services. So it's a mouthful, but it's a lot of departments that that do interact with each other and collaborate with each other. I'm also the department's liaison for interagency and system partners and contracted service providers in these service areas, which apparently was enough to tag me for this role as well.
That's such a great background, and I
Sure.
so appreciate you sharing it. Tell us about like these, there's a lot to implementation of these new services. How did you approach it overall, and how did you even get started?
Yes. So, well, a long time ago, I guess in a galaxy far, far away, and prior to my involvement in this work, implementing the Consolidated Appropriation Act and reentry requirements was really seen as a fiscal matter. Most of the work was happening behind the scenes. The companies we worked with, along with our state health insurance agency, which is the Mass Health, would really just extract the information from our system, submit it to Medicaid for reimbursement. No one really knew this was happening except for really a few people in IT and fiscal. A lot of people in our own agency didn't know it was happening. So when I came into this position, our fiscal department was turning over. We had very little fiscal budget support. CAA had sort of fallen off the radar, but the implementation date of January 1st, 2025 was approaching. So I was tagged to oversee the work. And I have to say, I quickly realized it wasn't really a legal and IT priority. It was really identifying and really understanding the work that needed to be completed by all the departments that I was overseeing, which was our medical health, behavioral health, education, substance use, and our youth and family focused direct care staff. So really the first thing I did was try and read everything I possibly could on CAA and reentry. We had a great partnership that had started with our Mass Health, our state insurance agency. So we started regularly scheduled weekly meetings, just really to go over CAA and reentry. What was it all about? What were the requirements? Just to try and really understand it. I started bringing together the directors of my department. So our directors of health services, clinical services, substance use, community services, and then added our data and research teams, because what we really needed to do was match the services that we were providing with the data that we were collecting. And I don't even think we had anybody from fiscal early on in those meetings. A strong practice that you've noted already was that we already enrolled youth in Mass Health right from the very beginning. So off the starting line, we really knew we had a system that already captured all of our young people. So we really started just focusing on services. We started small. So we broke up the work to really first focus on the CAA requirements for committed youth. So those are required services. We knew we would get to detention, which was not yet required, but focused on our committed youth. And then really got down to what are the bare bone requirements. We focused on identifying the services that we were already providing using the EPSDT. And then what services did we need to ramp up or, frankly, we're missing completely to really be sure that we had CAA compliance. So thanks to our Director of Health Services, we also were in a good space because we had been following EPSDT requirements or guidelines for years, which gave us another great platform. And then we really needed to focus after we identified the service on how we were going to be documenting them to make sure that we could consistently make sure that they were happening. So once we had the services in our system, we worked then with our data and research teams to develop a tool that would then extract those services out of our system. We don't have an electronic health record system, so that was sort of a task in and of itself to figure that out. And then with that tool, we can identify youth that are due to be released within those 30 days to see what services they have and then what services they still need so that we're in compliance. So that was really the screening and diagnostic part of the work. We then moved to targeted case management, again, focusing on what we are currently providing that fit into that definition provided by the federal regulation to then figure out what else were we missing. In between those meetings, we started to engage again our IT data and fiscal team sort of on a parallel track. Again, you've made note of it because we wanted to make sure that we were identifying the services, we were entering the services, but we needed to make sure our systems were talking together so that we could actually extract the services and actually get the Medicaid reimbursement. So, you know, in closing, I would say we focused on really what we were currently providing to start with, compared it to what was required, and then just started to try and fill in the gaps.
Got it. That's really, really helpful. It sounded like you had a broad collaboration within the
Yes.
department and really pulled in the data and
Yeah.
IT people and did a like analysis of where you were already strong on the enrollment side and to some extent the service side, and then where you needed to fill in the gaps.
Yeah.
It's really, really helpful. So there's a lot to that of like putting the pieces together. I'm wondering if we could take a step back from the nitty gritty and just like if you could reflect looking back on it as what was the vision that you all used to guide the work, and were there any outcomes that you had in mind as you started?
Yeah. It would be probably too shallow to say I had show me the money running through my head, which was, you know, that carrot, you know, you want to really try and see what we can recoup from all the work. But then, you know, that was sort of like the bonus, I think, for us. It was really motivating and I would say validating to know that if we focused on all the needs identified, that you've identified early in the presentation, the physical health, behavioral health, substance, dental, case management services like housing and school, pro-social activities, all of that, you know, which I think everyone is doing in some manner. We could actually recoup some money for that, which is unusual, right? In government, you know, you're actually going to get paid maybe or get a bonus for all the work that you're doing. But I think the vision that we all had coming together was, especially what you've highlighted in the presentation so far, is that this work was going to make us better as a state agency by providing those essential services that we've identified to actually make kids better. So the work the work that we were going to do or hope that we would do would make us more effective at the work. It would make us more efficient between departments because we were really going to identify what departments we're doing and then how we were going to connect with each other. And then hopefully it was going to make us more consistent across the state and not necessarily just have pockets of good work and others trying to kind of keep up. So we really tried to use this as an example at DYS to, you know, agree on assessments for example, make sure that we're all using the same assessments, that we're making sure that we are documenting the results, that they're meaningful to the youth that we're being assessed. So identifying those individual services that each of those kids need. And that we're providing all of those services statewide. Same with health services, for example, you know, that we're providing the same types of services in our health department to the kids, but then we're also really targeting at what their actual needs are. So when it came to outcomes, you know, I guess, again, I would reiterate that effective services more efficiently and consistently was sort of the really big outcome and what we're still striving for. You know, and maybe at some point we can then look back and see, are we increasing the services to youth that we might have been doing before CAA? Are we increasing the money or the reimbursements that we're receiving? And, you know, bigger outcome, are we possibly reducing a return to custody?
Those are great outcomes. So it sounds like for Massachusetts, it was a combination of like trying to achieve some long held goals of reducing cycling through the justice system, as well as meeting the needs of youth better and making things more consistent and efficient. And underlying all of that is this fiscal benefit that comes to DYS by having Medicaid start to pay for services, which of course, without this change in policy and law wouldn't be possible because Medicaid historically had been barred from covering any services when when Medicaid beneficiaries in the justice system.
Right.
I'm wondering if you could say a little bit about who your key collaborators were and how it worked.
Yep. Yeah, we couldn't have done this without a lot of collaboration. Because again, as you referenced earlier, it takes a lot of different systems to work together to actually make this happen. I think the first one again was making sure our internal collaboration was tight, that we had it on everybody's work to-do lists. All the directors that I spoke about, along with our IT departments and our fiscal departments, really had to be in the know to some extent as to the work that was doing and where we were going. So we had those meetings occurring regularly. And then I would say our state insurer, our Mass Health agency, was the next really key component. We needed to make sure the services that we were identifying fit into their definition of services that could be reimbursable, to make sure that where the systems were talking to each other. You know, for an example, some of those decisions were easier, through EPSDT, for example. We all have to do, and we know we have to do an annual physical. When that annual physical had to happen, was another conversation. So it was making sure that we were having those conversations together as we were moving forward with the identified services. And in addition, I guess we connected regularly with our adult corrections. We shared ideas on, for example, what assessments people were using, how people were capturing the information and documenting it, and then just kind of general moral support, because this was all new to everybody. So everyone was sort of, figuring out as we went along.
It can be so hard to take on something new, but
Yeah.
I love that you used your experience to cross-pollinate into the adult system, because as I said at the outset, I think the juvenile justice piece of this is coming along a little bit faster than the changes in the adult system, but clearly there's a lot to learn.
And it was really helpful to collaborate too in other areas. So other initiatives. So this helped us form the relationships and identify the people that we would need, not only for CAA and reentry, but, for just general enrollment questions or general, custody questions. So it helped. It was a nice opportunity to develop some more relationships with people.
Oh, that's great to hear, because I know a lot of time in government or any complex organizations, it can be really hard to de-silo or work across silos. And so it's great to hear that this policy change is helping to
Right.
make something happen that is probably people wanted to have happen for some time.
Right.
That's great. That does sound efficient, to your point.
Yes.
You've been reflecting on their past experience on implementation. I'm wondering if you could just share with us a little bit about where do things stand now in terms of implementation?
So I can say that I know we're in compliance with CAA. I know that we're providing the services that we need to provide. And I think we're still putting the finishing touches on finalizing what the definition of our targeted case management services are, because those are a little bit harder to define. And we need to work on perfecting our documentation to show our compliance in the event that that's ever necessary. And then I think we want to make sure that we're working closer with our external data and fiscal partners to make sure that we're really maximizing that reimbursement.
Yep, that sounds great. And do you have any goals for further down the road, understanding that you're fully compliant now? I wonder if
Yeah,
anything in the
definitely.
headlights that you're
Yeah,
working towards.
yeah. I think now, we focus on detention youth, because that wasn't a required part of CA. It was not considered mandatory. So we want to make sure that we're looking at detention and providing those youth more services as much as we can. I think we want to work on a better way. And this is a project we're working on with this Mass Health, which is how can we ensure that youth who are transitioning out of DYS stay involved in the Mass Health system so they can continue to receive those services. That will then help them in the long term. Again, increase the accountability for services to increase our reimbursement. I dream of an electronic health record system someday with my health director. Maybe that will happen. And then probably, expand to that 90-day through reentry, where we're really focusing on the 30 days before and 30 days after.
That's great. I think you said something that's so important about the ongoing access of youth to health services through Massachusetts Medicaid program, Mass Health. And I think the way you articulated that, Lisa, really jives with the whole goal of that Congress had in mind when it created these provisions, which was using the reentry period as a launching off point.
Yeah.
So that young people are getting these comprehensive services. And that's really, I think, where there's so much potential to change people's lives, improve their health, and hopefully keep people from cycling in and out. You've mentioned the EHR a couple of times, so I thought I might just
Mhm.
ask, like, what role did you see EHRs playing? How would it be helpful to you, and how did you do without it?
Yeah, I know, I don't know. Well, we have an excellent health services director, honestly, and we have a fabulous relationship with our health care providers who we contract with within our state programs. So they came up with a system that they could live with that collects the information. Sometimes it's in paper.
Yeah.
Hopefully it then gets into our enterprise management system. And then we worked very closely with our data and research team who partnered with us incredibly well to then create sort of our own tool that would extract the information. So we, it was just kind of piecing it together.
Got it. So in the interim, you kind of built your own
Yeah.
to make it all work. I think
Yeah.
this question comes up so often from the states we work with on reentry waivers or CAA is, I think people recognize the value of the EHR, but sometimes it takes some time to get there. And the type of education you described is like exactly what it takes in the interim. So that's really, really helpful. Recognizing that states are, still in the stages of implementing the CAA across the country, what would you suggest to a state that's, in an earlier stage or even, just starting out on implementation?
Yeah, I would want people to realize this work really does involve all aspects of juvenile justice. So again, thinking about that it's not just a fiscal or a data piece, it really involves all of the departments and all of the specifics of juvenile justice. So, first thing, educate yourself again on CAA and reentry. I think the issue brief that you're highlighting here today by HARP is an excellent document to start that education, share it widely within others in your agency so that people are on the same page and have at least an understanding of what they're getting into. And then honestly, find a few people who you like to work with and create a plan because it's going to grow and it's going to kind of create, different pathways. But I think a small amount of few people that you like, get together, create a plan, start with what's required in CAA, figure out what you're already doing, and then create that larger team to help fill in the gaps for services, documentation, and reimbursement. I would say, again, going back to that vision question, use this as an opportunity to build upon the services that you probably already have, knowing that these are required services and they're all proven to help improve the health and safety of the young people we serve in the long term. So it's a really, it's an effort that really should hold some confidence and some excitement for agencies that are in this business. And then finally, I would say make sure your state insurance agency and your state finance agencies, your IT departments, ensure that they're kind of involved and can understand what you're doing so that you make sure whatever services you're identifying can then be translated into the data that then can result in the reimbursement. So you have to kind of keep everyone in the know as you're moving forward.
That's really helpful. I love the idea that this work can be exciting and you get to work with people you want to work with.
Yeah, you gotta make it fun.
Sells itself. I'd like to transition us now to some questions from the audience. We've got a couple of already, and I'd love to invite Margot and Lisa to join the conversation as well. But as they do that, Lisa, I think there is one question specifically for you here, which is that the audience is interested in learning what assessment you used for the youth that you served through these Medicaid provisions.
So we use a number of assessments. I think actually one of them or a few of them are highlighted in the brief. The YLS CMI was one of the screening tools that we were using. We also use Bright Futures was one of the ones we used for just general diagnostic. I can get some more information to you. The YLS CMI was probably the biggest one that we found. Really hit a lot of the targets that we were looking for. We also use the MAISY here in Massachusetts. So that was another one that we found was suitable. I believe the adult organizations are also using the MAISY. Those are the ones that the Jazzy is what we use for substance, but I think actually the Maisie was sufficient, and the YLS also kind of came under the were sufficient for substance use.
That's great. So it sounds like there were a range of
Yeah.
evidence-based assessment tools that you chose from.
Right.
And as you point out, we talk about some of those assessment tools in one of the appendices of the brief.
Yes.
Because we really wanted to not just highlight the great work and the implementation practices that states are already doing, but where are the opportunities to
Yeah.
bring evidence-based assessments and ultimately evidence-driven services to youth and young adults. Our next question, Lisa Elby, is about the interaction between implementation of the CAA youth continuity of care requirements and the 1115 reentry waivers that 19 states have approval to carry out, including Massachusetts. And I'm wondering whether you interacted with the reentry waiver implementation and how those two related to each other in Massachusetts.
So I did not have a lot to do with that waiver. That actually was handled through our fiscal department. And I do know that it also was a lot of our our executive office for I think handled a lot of the work because it had to do with a higher level of authorization. So I did not have a lot of work when it came to actually getting the waiver, but the states that have submitted the waiver, we can actually get information and examples if people are having a hard time figuring out where to start. I'm pretty sure that there are some examples that are a path that has actually been started to be warned about how to do that.
Yeah, I'd love to bring Margot into this as well. I see that she anticipated me by quickly coming up with you. Margot, what would you add to the question of CAA and reentry waiver coordination?
Yeah, I was halfway into typing a response, and then I thought this is the great one for the whole team to hear. What we've seen across states is a lot of coordination between the teams that are trying to carry out the CAA services and the waivers. It is a little bit dependent on how the state's waiver is organized, whether they are including only adult facilities, if they're focusing on certain types of diagnoses, like people with active substance use disorders, or if they're opening it up to everybody, if they're kind of looking at specific services they're going to do. But that being said, a lot of the infrastructure that is needed to do the CAA services and the waiver services are very similar. Things like EHRs, if you have them, the ability to share information between correctional facilities and Medicaid and with community providers, that need for cross-sector collaboration, the need for facilities to really be able to screen people at entry for Medicaid eligibility and enrollment. So, what we have seen in other states is a lot of collaboration across these two policy implementations, just because there's a lot of the pieces that undergird the services that is the same for each. But Vicki, feel free to add to that.
No, I think you really covered it. We've got a few more minutes for questions, so if other folks have got some, please add them to the chat. We've got a nice queue, but we always want to make sure that we're using all of our time to inform people. We have a question about engagement of family members, and I know that when it comes to the health and well-being of youth, the role in the health of the family is also important. So I wondered, Lisa Belmarsh, if you could kind of speak to how you approach that in Massachusetts, and then Lisa Pilnick, would love to hear your perspective on the roles of families as well.
Yeah. Family members of the youth are, I think, intricately involved in all aspects, or we try to make sure that they're intricately involved in all aspects of the youth's care right from the very beginning. So they're aware of what treatments or health services or education services are happening within the residential placement. And then they are part of that transition planning, which are what are the needs that our youth is going to need upon transitioning, whether it's housing, whether it's job, whether it's skills. So really trying to involve them in all of that work, and make sure we're all on the same page, people understand what the treatment plan is, what our community service plan looks like, and what it is, what we're looking to try and get to, what the needs are for that youth. We've also started a practice where we have family partners, that are part of our service, our community service network. So a family member can talk with a family partner who is employed by DYS, if they don't want to talk to one of the DYS and, caseworkers or administrators. So that's another way that we're trying to really involve families, and make sure that their voices are heard.
Really helpful. Lisa Pilnick, what would you add?
Yeah, and if you'd like, I can also try to take a crack at the other question about counties after I talk about family engagement. But the other thing I want to say as I'm answering this is that there are so many experts who are watching this webinar and bringing your own experiences with doing this implementation work. So please feel free, as I'm talking, to type in the chat if you have any answers to any of the questions that any of your peers have posed on here, because I'm sure there are many good answers. So in terms of family engagement, I mean, this is very much in line with what Lisa says, Lisa B said, but the way that we think about that in terms of nationally is you want to have youth and family engagement at the individual level and then at the systemic level. So these are, Lisa gave examples of how these were happening in Massachusetts, but when you are talking to individual young people and families about what are their needs as they are looking to reentry or while they are in custody, not just using sort of boilerplate or cookie cutter plans or services, but really saying like, what is it that you need? What is it that you would find helpful? So that's kind of how we would do that at the individual level. And then at the systemic level, that is talking to young people and families when you're designing programs. So, when we are looking at an RFP for a provider who's going to provide some of these services, for example, do we have families and young people who have experienced justice involvement, helping us either design the RFP or score it or both? Do we have feedback on what types of services we should be RFPing for, et cetera? And then I would just say that even though for this topic, we're talking very specifically about health needs and the CAA provisions and Medicaid and CHIP funded services, the more you have that youth and family engagement already in play, already institutionalized, the more you already have an advisory group that has young people and families on it who you can routinely meet with and ask when different questions come up. The more you have systems in place, so when you're doing case planning, that you always talk to young people and families and really get their input, so you could do individualized and family and youth planning, the more it'll be easy to do that when a specific issue comes up, like, oh, there's this new opportunity through the CAA we want to grasp. You already have kind of those systems in place to do that engagement and get that input to make the work that you're doing stronger. And that is the sort of overall reason for engaging with young people and family members, is that they are the experts on their needs and what services will most help them. And so it helps you as a systems stakeholder be more successful in your work when you are listening to young people and families. Really quickly, I know there was a question about lessons learned and counties. For this paper, we were really talking to state level leaders, but I will say that one of the things that we heard from them that I think would make sense is that this is going to look really different in every county, especially when you're talking about rural counties, when you're talking about different levels of needs for substance use or physical health needs. If you live in an area where there's high asthma rates because of environmental factors, every community is going to have their own needs. And so I think the big lesson learned there is flexibility. So the more that the state partners are giving flexibility to the counties, and that the counties are saying, well, we really need to look and see what are the needs specifically locally. If we're going to learn from other people, we need to learn from counties that are similar to us in terms of their populations, their geographic spread, et cetera. So that's my quick answer to that. And I definitely welcome feedback from any of my other co-presenters or anyone in the chat if you have other thoughts on that.
So Vicki, I also wanted to just add in with regards to the family question. I recall we do also do family advisory councils. So to Lisa's point, to try and make sure that we're really providing the services that families feel like they need, bring them in as an advisory. And then I also noticed that there was a question here about whether our providers who are within our residential programs bill for services, and they do not. So they don't bill. We then look for the reimbursement through what the services are that they're providing.
So you, as the DYS, are billing Medicaid, Mass Health,
Yes.
not the providers.
Right.
Okay. Okay.
Yeah.
That's really, really helpful. We're just about at time. I am going to put in the chat for the person who was interested in counties, a paper that HARP and one of our partner organizations put out earlier this year on work that 12 California counties are doing implementing their Medicaid reentry waiver. So not specific to the CAA, but I think there are some really great lessons learned from some of the first counties, in fact, the first counties in the country who are implementing Medicaid reentry waivers. Thank you all thank you, Lisa Belmarsh, for the work you did and for sharing it with us this afternoon. Lisa Pilnick and Margot, thank you so much for your excellent substantive work and presenting. And I'm handing it back to Michael to close us out.
Thanks so much, team. This has really been a great conversation. I really appreciate your partnership. We want to encourage everybody to reach out both to the Center for Youth Justice and to HARP. If you have any additional questions or need any further support, you see on your screen here HARP's website. As I mentioned, all of the resources that we talked about today are available on the HARP site. Not just the issue brief, but the slides from today's presentation and related resources. So please be sure to check that out, and you can sign up for HARP's newsletter using the QR code on your screen as well. I want to thank all of our presenters for being with us. This is a really important topic, and we are really hoping that the field continues to embrace this as a key opportunity to improve health outcomes for young people who are involved in the justice system. We at the center continue to host certificate programs and other initiatives designed to support the field. And we really view this as a key opportunity in an important dimension to advance those outcomes. So thank you all for your interest and your dedication. Please be in touch. Take a look at our websites, and we look forward to continuing to support all of you as you work on behalf of young people throughout the country. Thanks, and be well.